21. And as you all know, it's very clear now, the number of questions has been reduced this time. It's a clear indication that many of the clinical questions are going to be asked in the exam. So what I will try to do here is that I'll discuss the higher topics which are required for your exam, NET PG exam, like based on the previous year questions and all. Apart from that, I'll discuss those topics which are mainly having a clinical correlation, like where anatomy has a role to play in the clinical correlation, guys. Okay. So without any further ado, let's get started with our QRP here, anatomy QRP, and this is your faculty here, guys. So let's get started with the very first concept, and I have also included some of the clinical questions here. So let's begin with the very first concept here, guys. Yes, hello everyone, welcome here, guys. Yes, welcome Rakesh, welcome Muzammil Hussain, welcome Alia Sultan. A very warm welcome to all of you guys. Good evening. Now to begin with the very first thing, let me just read this question along with you here. A 6-year-old boy presents with ear pain. The pain started 2 days ago, increases when he touches the affected ear or lies down on it. Okay, there's ear pain, fine. The first keyword there. The patient recently starting swimming lessons at a local outdoor pool during the past week. On physical examination, the tragus is tender to touch and the external ear canal is erythematous and then demonstrates white colored discharge. It is demonstrating a white color discharge, guys. The tympanic membrane is a pink gray with no perforations in that one. The anatomical area that is most likely infected in this patient is derived from which of the following embryological structure. So hope you are able to understand here. The moment you look at that question, you will be easily able to understand that it is actually a question related to embryology. Okay, this is a question which is actually related to your embryology part, guys. And let's see, okay, how to deal with this type of question. Now, all the students who are actually preparing for NET PG this September here, I want to tell you one thing, guys. Whenever you're coming across a clinical question, try to answer that clinical question in a retrograde manner. That means don't go as if we were solving the one-liners. Okay, start from the options. So now let us do it in the opposite manner. Now, just now I read the question, right? Instead of reading the question, let's read the option first. Okay, the options are like first pharyngeal pouch, second pharyngeal pouch, second pharyngeal cleft, and first pharyngeal cleft. So what will happen is that I'm just trying to tell you the trick how to solve the clinical question. First you read the options first. The moment you read the options there, automatically what will happen, your thinking will be narrowed down. Out of 19 subjects, just imagine the situation during the exam. Out of 19 subjects, first of all, the moment you see there the cleft, the pharyngeal pouch, you will narrow down to anatomy. This question is related to anatomy, and then you will be narrowing down, this question is related to the embryology of pharyngeal apparatus. Understanding? So that is the best way to deal with the clinical question. That will actually save your time. That will save a lot of your time during the exam. So this is the embryology question. And then what you do is after that, read the last line. The anatomical area that is most likely infected in this patient is derived from where? Oh, you're not getting any clue from the last line. So now then you go and read the entire question here, guys. Are you understanding the trick here? The best way to solve the clinical question, first of all, you go through all the options, then look at the last line and then look at the entire question. Then if you're not getting option there, the entire question is all about the ear, external ear. And external acoustic meatus will be derived from where? Let's just first of all discuss that topic and then come back to the question. So in this way what will happen? We'll also discuss the embryology topic as well as come back to the clinical question there, guys. Yes, hello everyone. Hello Aditya, hello Bhavya, hello everyone there, guys. Wow, I even got some answers there. Lovely, good. Now I think at this point of time when you are preparing for your exam, you people are already perfect with this diagram here. On the outer side you'll be having your ectoderm, and ectoderm is the one which will be going to form your ectodermal clefts. Fine. And endoderm is the one which is actually going to form the pouches there, and those are endodermal pouches. Guys, actually in your textbooks and all, the naming will be the pharyngeal clefts and the pharyngeal pouches. But I am changing the name a little bit here as ectodermal cleft and endodermal pouch there, so that my students can easily remember that the clefts are derived from ectoderm and the pouches are actually derived from the endoderm there. Perfect. Now, how many clefts do you have? You'll be actually having like 4 clefts here. Number 1, and then there will be number 2 here, then there is number 3 here, and number 4 here. There are totally 4 clefts. And out of that 4 clefts, remember, the first cleft is the one which is going to form the external acoustic meatus. It is the one which is going to form the external acoustic meatus, and along with that it is also going to form the outer layer of tympanic membrane. The first cleft is the one which is going to form the external acoustic meatus as well as the outer layer of tympanic membrane. Okay. Thank you, Dr. Suveta. So that is the one which is going to form your external ear. Then what about the second, third and the fourth cleft here? Remember, that will be obliterated, it will be closed. You can very clearly see there the second arch in the middle, the mesoderm, the second arch in the middle is growing very much faster, and it is going to overlap onto the second, third and the fourth cleft, and it is going to close them and nothing derived from there. Now you can do one thing here, guys. You can even compare this diagram with our body right now. So pharyngeal apparatus in this region over here. Now in this region we'll be having the pharyngeal apparatus, and the outer one will be your ectoderm, and ectoderm is going to invaginate there. It is going to form the ectodermal clefts. And the first ectodermal cleft is the one which is going to form your external acoustic meatus along with the outer layer of tympanic membrane. And the second, third and the fourth will be completely closed and nothing derived from there. So you can clearly see here, after external acoustic meatus, you don't have anything, and any other structures derived from there. Next one. Then on the inner side, you are able to see the pouches there, endodermal pouches. There will be a first pouch here, and the second pouch here, the third pouch here, and the fourth pouch there, guys. The first pouch is going to come and meet with the external acoustic meatus. So therefore, yes, it is the one which is going to form the middle ear cavity. The first pouch is the one which is going to form the middle ear cavity. Along with the middle ear cavity, it is also going to form the eustachian tube. It is going to form the eustachian tube. Along with that, it is also going to form the inner layer of tympanic membrane. Inner layer of the tympanic membrane. So middle ear cavity along with the eustachian tube and the inner layer of the tympanic membrane there, guys. Second pouch, it is the one which is going to form the tonsils, that is palatine tonsil, but not the entire palatine tonsil, guys. Remember, only the epithelium of the palatine tonsil. Only the epithelium of the palatine tonsil. And suppose if you want to know, then what about the actual palatine tonsil? I meant to say the lymphoids part of that is derived from the neural crest cells. Okay. Yes, TM actually stands for tympanic membrane. TM stands for tympanic membrane, guys. Okay. So palatine tonsil are actually the lymphoid part of that one is derived from neural crest cells. Only the epithelium will be derived from the second endodermal pouch, second pouch. Now the third pouch here, it is the one which is going to form thymus, and I always tell my students to remember with the rhyming word third pouch is going to form thymus, and because the thymus has to actually migrate down, along with the thymus, remember, it is going to form inferior parathyroid gland. So, along with the thymus, it is going to form the inferior parathyroid gland. And the fourth pouch is the one which is going to form the superior parathyroid gland. So, it is going to form what, guys? Superior parathyroid gland. So the first pouch, I repeat again, guys, the first pouch is going to form the middle ear cavity along with the eustachian tube and the inner layer of the tympanic membrane. And the second pouch is the one which is going to form the palatine tonsil, the epithelium part of that. If you want the exact lymphoid, the lymphoid part is the one which is going to be derived from the neural crest cells. Okay. And then the second pouch is done. Third pouch is the one which is going to form thymus. And thymus, after forming here, it has to actually migrate down because actual location of the thymus will be in the mediastinum. So therefore, remember, along with the thymus, there will be inferior parathyroid gland. And then the fourth pouch is the one which is going to form the superior parathyroid gland. Superior parathyroid gland, guys. Done. Now, after learning all the derivatives, see, in one diagram itself, we have completed, guys, everything here. In one diagram itself, we are done with everything here, guys. The ectodermal clefts and the endodermal pouches here. Done. Now one more important thing, let's have like one more conclusion from this diagram here. Between the external ear and the middle ear, you'll be having the tympanic membrane here. Between the external ear and the internal ear, the middle ear, you'll be having the tympanic membrane. And tympanic membrane, I hope you have learned, it is derived from all three germ layers. And welcome here, it's absolutely true. The outer layer of the tympanic membrane is derived from ectoderm. and the inner layer is actually derived from the endoderm, and in the middle you're having mesoderm. So therefore tympanic membrane is derived from all three germ layers. That is one thing clear from here. And one more thing, what is going to happen here, because this second arch is derived from where, guys? Arch is actually derived from the mesoderm, and because the second arch is actually growing faster, then what is going to happen, there will be a space enclosed here, and this space which is enclosed here is actually, yes, that is, there will be a space enclosed there, guys, and that space will be now, right now in your body and my body, if you see here, it is completely closed. But in some people, what is going to happen, that space is going to persist, and if that persists, then that will lead to a condition, and yes, that condition is actually referred to as the branchial cyst. What is that one? Branchial cyst. So normally क्या होना चाहिए? Normally what should happen in your body and my body right now? Yes, this is completely closed there. So after external caustic meatus, completely it is closed there. Okay, so nothing derived from there. So normally what should happen, should be closed, but in some people, if that space persists, and if it persists, then that condition is known as the branchial cyst. Branchial cyst, guys. If that sinus persists there, it is known as branchial cyst. So that is one important clinical correlation here that you have to remember, guys. Is it okay? So that is about the ectodermal clefts and the endodermal pouches. Whatever it is, from here we understand the external ear will be derived from where? From the first cleft. Now coming back to our clinical question that I have showed you in the very beginning, guys. Yes. So if there is all this condition here, there is a ear pain, external ear canal is erythematous here, there is a white color discharge and all those things. So it's derived from where? The external ear is derived from where? That is from the first pharyngeal cleft. और मैंने आपको ना स्टार्टिंग में ही कहा था, I told you that in the very beginning itself that normally the name is pharyngeal cleft and the pharyngeal pouches, but I am wantedly writing here as ectodermal cleft and the endodermal pouches, so that my students should remember that clefts are derived from where, sir? The ectoderm, and the pouches are derived from where? Endoderm. Zenif Islam is asking, sir, epiglottis will be derived from where? Zenif Islam, epiglottis will be actually derived from your hypobranchial eminence. When you look at this pharyngeal arches, you know, all the pharyngeal arches from inner side, you will be able to find the development of the tongue. And yes, Dr. Zenif, when you learn about the development of the tongue, in the development of the tongue, you are having like lingual swelling, and along with the lingual swelling, you will be having tuberculum impar, and along with the tuberculum impar, you will also have hypobranchial eminence. And that hypobranchial eminence is divided to the cranial part and the caudal part. Caudal part of the hypobranchial eminence is going to form the epiglottis. Caudal part of the hypobranchial eminence is going to form the epiglottis there. Is it okay, Zenif? Fine. The caudal part of the hypobranchial eminence. Now let's go ahead with the next concept. So the second concept here in the quick revision program, QRP. So the first concept is done, in which we have learned about the derivatives of ectodermal clefts and the endodermal pouches is done. Okay. Now welcome to the next one. The next concept is about the, I have selected like next concept is, that is the neuroanatomy here. Why? Because there is actually one clinical question which is given from here in the previous exams also. So based on that pattern, I am trying to discuss all the topics here, guys. Look at this. The moment you look at this diagram here, you are able to see very, very clearly here, guys. This one here will be the midbrain. This here will be the pons here. Perfect. And then this one here will be the medulla oblongata. So I'm trying to discuss in the same manner, guys, I'm trying to discuss in the same manner that we are going to cover the concept as well as the image based question also, so that the moment you look at this image here, you should be able to answer that one. So image based question is also, as well as the clinical correlation. Yes, I'll tell you the clinical correlation also in every topic, don't worry about that one. Okay. Now the moment you look at this diagram, midbrain, pons and medulla, yes guys, this is nothing but the brainstem, and that too, this is the ventral aspect of brainstem. This is the ventral aspect of the brainstem. Now one important thing that every medical student will know, the ventral aspect of the brainstem, it will actually give rise to the cranial nerves. And how many cranial nerves are going to originate from here? 3 to 12. Okay. Now the third cranial nerve is going to begin from the midbrain. You can clearly appreciate here, this is the third cranial nerve here. And even the fourth cranial nerve will also originate from your midbrain only. But observe very carefully, it's going to originate dorsally, then take a turn and then come in the front, guys. Is it okay? Dr. Ramu, it's not about the FMG or NEET PG nowadays, it's all about the clinical questions. Many clinical questions are being asked in every exam that you are preparing for. And knowledge is always knowledge. So just attend this and try to learn something. Try to gain something in our next 1.5 hour of the session here. So which cranial nerve is going to begin from the midbrain? The third and the fourth one. The third nerve will be originating ventrally and the fourth nerve will take a turn and come in the front, guys. Now I want you to remember a few points regarding the fourth cranial nerve, sir. The fourth nerve. Number one, it is the only cranial nerve which has got the dorsal origin. It is the only cranial nerve which has got the dorsal origin. And number two, it is the nerve which has got internal decussation. It is the nerve which has got like internal decussation. Now, what is the meaning of that? Decussation, it's crossing. Decussation means what, guys? It is actually crossing, and it is actually crossing inside the midbrain only. That is the reason why it is known as internal decussation. Internal decussation. Next one, apart from that, remember, it is the cranial nerve which has got the longest intracranial course. The longest intracranial course. Listen that word carefully, guys. Longest intracranial course. Why? Because longest intradural course is for abducens nerve, number 6, and longest intraosseous, inside the bone. Yes, that is nothing but your facial nerve, the 7th nerve, guys. And apart from that, it is the thinnest cranial nerve, as well as, remember one more point here, that it is the smallest. It is the thinnest and the smallest cranial nerve, guys. These kind of words, what they will do is, these kind of like keywords, they are going to slip in between the questions. Okay, they are going to slip in all these words between the questions there. So try to learn them. The fourth nerve has got dorsal origin, it has got internal decussation, the longest intracranial course, as well as it is the thinnest, and it is actually the smallest cranial nerve. Lovely. Now after that, there will be cranial nerve number 5, you are able to appreciate here, coming out or exiting out from the pons. But for your NEET PG exam, I want to be like more specific there. It's actually exiting from where? It is exiting between the pons here, at the junction of pons here, as well as what is this one here, guys? This one will be the middle cerebellar peduncle. Middle cerebellar peduncle. Fine. So I hope you all remember there will be like 3 cerebellar peduncle. There will be like superior cerebellar peduncle, the middle and the inferior one. And middle cerebellar peduncle is the one connecting the pons to cerebellum behind. And exactly at the junction of pons and middle cerebellar peduncle exits your cranial nerve number 5. Then this one here will be the cranial nerve number 6, and then the cranial nerve number 7 and the cranial nerve number 8. 6th, 7th and 8th will exit out from the pontomedullary junction. You are able to see that there is a pons and medulla at the junction of pons and medulla. Pontomedullary junction, yes, the 6th, 7th and 8th nerve will exit out. And now welcome to the most important thing, medulla oblongata. In the medulla oblongata, you are able to appreciate one elevation here. This one is referred to as pyramid and pyramid here. Then there is an olive here lateral to that, and here also there is an olive. So pyramid and pyramid and olive and olive. First, let me finish off with the cranial nerves, guys, okay. So this is the cranial nerve number 9, then 10 and 11. 9th, 10th and 11th, these 3 cranial nerves are going to exit lateral to olive. They are going to come out lateral to olive. And the 12th cranial nerve is going to come out between the pyramid and olive. The 12th nerve is between the pyramid and olive. Pyramid and olive. Fine. So as I told you in the very beginning, guys, almost as I told you, like which cranial nerves are going to originate from the brainstem? 3 to 12. So 3 to 12 are going to originate from the brainstem, hence proved. And now welcome to actual clinical question which I am trying to discuss here. Yes, my dear friends, tell me what is the name of this elevation here? This elevation is actually the pyramid. Now you got to know the reason why it is elevated. What is the reason? Why is that elevation pyramid there, guys? Why? Because just beneath that, the pyramidal tract fibers are passing from there. So because that pyramidal tract is going to pass from there, that is the reason why it is elevated, guys. Okay, ji. The pyramid is due to what? It is due to the tract. Which tract, guys? That is your pyramidal tract. Now, I hope all of you knows that pyramidal tract is another name for corticospinal tract. It is the most important descending tract that you have to know about. So pyramidal tract or corticospinal tract is going to descend down. From the cortex, it is going to descend down midbrain, pons and medulla. Now listen very carefully. We all know very well what is going to happen here. That pyramidal tract fibers are going to descend down in the medulla oblongata. In the lower medulla, 90% of the fibers are going to cross on the other side. And they are the one which are going to form the lateral corticospinal tract. The lateral corticospinal tract will have 90% of the fibers which are crossed fibers from the other side. Then what about the remaining 10%? The remaining 10% of the fibers are going to pass on the same side and they are going to form what, guys? They are the one which are going to form anterior corticospinal tract. And then how many fibers there? 10%, and they are uncrossed fibers. Hope you are trying to understand my logic here, my planning here. So in this quick revision program, yes, in this quick revision program, what I'm trying to do is I'm trying to concise all the information at one place so that we don't waste our time learning different topics. So in one diagram itself, we are trying to concise all the topics here. So pyramidal tract fibers are going to descend down. That is the reason why that elevation is formed. And in the lower medulla, what is going to happen? The fibers are going to cross. And therefore, one of the most important question which is always asked in your exams, whether it is NEET PG or AIMS exams and all those things, guys, pyramidal decussation kahan hota hai? Where will the pyramidal decussation take place? Remember, it's in the lower medulla. Number one point that you have to remember here. And number two, second point, in one of the exam, what they have given is, for example, if there is a lesion in this region, star marked region, if there is a lesion, if there is an injury in the star marked region, if there is a lesion there, if there is an injury there, then what is going to get injured? Just now I told you the pyramidal tract fibers are passing from there. So if the pyramidal tract fibers are passing from there, definitely what is going to happen? It will lead to hemiplegia. It will lead to what, guys? Hemiplegia. Now the important thing where the students are actually confused is it ipsilateral or contralateral? Look at the region where the star marked region is given, sir. Star marked region is in pyramid, but where will decussation take place? In the lower medulla. That is why, yes, whatever region is marked there, it is still the fibers are not crossed. They are going down and then crossing. That means it will lead to contralateral or ipsilateral. It will lead to contralateral hemiplegia. It will lead to contralateral hemiplegia. As promised, delivered here. I'm telling you now, every concept I'm going to have a clinical correlation. So if there is an injury in the star marked region is pyramid, and if the pyramidal tract is gone, then it is opposite side. It is a descending tract. So it is the opposite side which will be actually affected. So contralateral hemiplegia. Very good, Dr. Shivagita. I hope your concept is getting cleared. So we are done with the corticospinal tract. We are done with the lateral corticospinal tract having 90% of the fibers. Anterior corticospinal tract having 10% of the uncrossed fibers. We are done with the crossing, that is pyramidal decussation here, taking place in lower medulla. And if there is an injury, then what is going to happen? It will lead to contralateral hemiplegia. Awesome. Crystal clear concept. Now just to complete this concept here, what is this elevation known as here? This elevation will be actually olive, and olive is due to what? It is due to the inferior olivary nucleus beneath that. There is an inferior olivary nucleus beneath that, sir. So below that there will be inferior olivary nucleus. Isliye that part will be actually elevated there, guys. Okay. Thank you, Dr. Boy. Let's go ahead now. Now after completing this concept here, now another very important thing, let me take you towards this part here. In this diagram here, you are able to appreciate this is optic chiasma, the crossing. And this part here will be the optic tract here. That is optic tract here. And this part here will be referred to as the crus cerebri. And we all know very well the crus cerebri is actually a part of your peduncle, cerebral peduncle. Fine. So there will be optic chiasma, the optic tract, and then the crus cerebri. Crus cerebri is actually a part of your peduncle. Okay? Is it okay? Fine here. It's actually cerebral peduncle. Now you have got the cerebral peduncle on one side and the cerebral peduncle on the other side. Between the two peduncles, you are able to find a depression. Yes, that depression will be nothing but interpeduncular fossa. Very meaningful name. Between the two cerebral peduncles, it is interpeduncular fossa. Now, in many a times in your exams, they'll be asking the contents of interpeduncular fossa. Number one, I hope you're able to see here, there will be infundibulum. That infundibulum is the one which will be attaching to pituitary gland, but what we have done here is we have cut and removed the pituitary gland from there. We have removed the pituitary gland from there. So, infundibulum along with tuber cinereum. I'm just writing in short. I hope you know that. We are just doing a revision program here. Okay, now. So, infundibulum along with the tuber cinereum. And then you are able to appreciate the mammillary body here and the mammillary body on the other side. Then there will be the posterior perforated substance here, guys. posterior perforated substance, and along with that the cranial nerve number 3. I repeat the 4 contents again. Number 1, infundibulum along with tuber cinereum. Number 2, the mammillary bodies. Number 3, the posterior perforated substance along with the cranial nerve number 3, that is your oculomotor nerve, guys. So these are all the contents of your interpeduncular fossa. Interpeduncular fossa. These are the contents of interpeduncular fossa there, guys. Perfectly done. And now Muzammil Hussain is asking, before crossing contralateral and after crossing, yes, it is ipsilateral. Of course, Muzammil Hussain. That is the reason why before the crossing it is injury. What was the question given in the exam? The injury is like here. Here means what's a before crossing. So इसीलिए before the crossing, if it is injured there, obviously the contralateral side will be affected. It will lead to contralateral hemiplegia. I hope this concept is clear now. So now, my dear doctors, therefore, the moment you look at this picture in the exam, yes, the moment you look at this picture in the exam, guys, will you fear now? Now there is no fear at all. Let them ask anything here. We'll be able to answer here, guys. Okay, lovely. Now, the way you people are like interested here, I want to deal with like one more thing here. If you allow me, let's go a little bit in more depth here. Guys, if there is a posterior perforated substance, then there should be even an anterior perforated substance also. Now, in this diagram, you will be able to see here, this will be the anterior perforated substance, guys. So, this here will be the anterior perforated substance. There will be anterior perforated substance. And in one of the exam, they have actually asked what will be the boundaries of this anterior perforated substance here. Wow. Look at the diagram here. On the medial side, you are able to see here optic chiasma. Easy. Posterior to that one, you are able to appreciate the optic tract. Anterior perforated substance, the question that was asked in the exam is the boundaries of that one. Okay. So, let's go a little bit in more depth right now. So, their boundaries. Medially, you will be able to find the optic chiasma. Posteriorly, you will be able to see the optic tract. And then in the exam, the question was laterally. Laterally, what do you have? Laterally, actually, there will be insula. What do you have on the lateral side, sir? There will be insula. But in the exam, they did not even give insula there. They have given the name of opening of the insula, and that is nothing but Lyman insulae. That is Lyman insulae on the lateral side. So let me repeat that again, guys. What are the boundaries of anterior perforated substance? Anterior perforated substance boundaries will be on the medial side, optic chiasma, on the lateral side, Lyman insulae, and posteriorly will be having the optic tract. Posteriorly there will be optic tract, guys. Lovely. So everything in this diagram has been done. Let them give this diagram in the exam. We are ready with any question here, guys. We are able to identify every structure over there. Is it okay? Yes, Bhagat, actually pyramidal tract is a descending tract. Pyramidal tract is actually a descending tract, and descending tract will be the motor. It is going to control the movements, and if there is an injury in that one, it will lead to hemiplegia. Okay. So it will actually lead to hemiplegia. But the confusion will be only with the contralateral and ipsilateral. That is what I actually wanted to clarify. That is cleared here with the help of this diagram, guys. I hope all of you are comfortable with this one here. This diagram is perfect, guys. So many things has been covered here. The image based things, let them ask any image based questions from here. Even like, let them give the cadaveric image. We are ready for that one also. As well as we are done with some clinical correlations related with this one here. Perfect. Now let's go to the next concept here in today's quick revision program, guys. Next one. In this next concept, I actually wanted to discuss the coronal section, and in this coronal section, I want to discuss, yes, Dr. Shiva is asking, pituitary is a content? No. Pituitary gland will not be a content of the interpeduncular fossa. Is it okay, Dr. Geeta? Perfect. Now let us discuss here the coronal section of the brain. But as I promised you, in every topic we are actually going to discuss the clinical correlation, and in this internal capsule I'll discuss one of the most important thing. Just be with me, guys. Okay. Now the moment you look at this coronal section of the brain, number one, yes, there will be lateral ventricle present here, sir. This is the one lateral ventricle here, and this is another lateral ventricle. And these two lateral ventricles are present in telencephalon. Learn medicine easy. Third cranial nerve originate from SC and fourth from IC. excuse me, I'll clarify here. Learn medicine easy, I don't know ये कैसा नाम है. Learn medicine easy. Third cranial nerve will originate from the third cranial nerve nucleus only, oculomotor nucleus only. Every cranial nerve will originate from its own nucleus. Fourth cranial nerve will originate from trochlear nucleus only. But that is at the level of superior colliculus and at the level of inferior colliculus respectively. So try to understand that very clearly. Don't use that, roughly, it's originating from superior colliculus. No. Every cranial nerve will originate from its own nuclei, but that is at the level of superior colliculus and inferior colliculus. That is what I want you to have a clarity. At the level of superior colliculus and inferior colliculus. I hope it is clear. Now, in this coronal section, you are able to appreciate here lateral ventricles. They are present in cerebral hemisphere, telencephalon. The lateral ventricles will now continue down into the third ventricle, which will be in the diencephalon here. Now, in this diagram, you are first of all able to appreciate that there is a bundle of fibers connecting the right half with the left half, the right cerebral hemisphere with the left cerebral hemisphere. And that bundle of fibers is referred to as your corpus callosum. In our regular classes, we have already discussed in detail the fibers which are going to connect the right and left half will be commissures, and the largest commissural fiber will be the corpus callosum. And now one more beautiful conclusion from here. You can clearly see corpus callosum is the one which is going to form the roof of the lateral ventricle. Clear. Now, apart from the roof of the lateral ventricle, now are you able to see a septum, guys, in between the two lateral ventricles? There is a septum between the two lateral ventricles, and this septum will be septum pellucidum. There will be a septum between the two lateral ventricles, that is septum pellucidum, and attached to the lower margin of that septum pellucidum will be the fornix. Extremely important for your exams nowadays. It's a trending topic nowadays, guys. Okay, so for example, this is the septum pellucidum here. Okay, for example, there is a septum pellucidum here, and the lower margin of that will be attached to what, guys? Yes, that will be attached to the fornix there. That is the fornix. Fornix is one such structure that you'll be able to appreciate that in almost every section of the brain. Every section, whether it is like, transverse section, the coronal section, as well as the parietal section, every section, you'll be able to appreciate the fornix there. Why? Because the way it is traveling is totally in 3 dimensions. Okay, so that's your fornix there. And septum pellucidum and the fornix, these two are the one which are going to form the medial wall. They are going to form the medial boundary or the medial wall of the lateral ventricle, guys. The corpus callosum is going to form what's the roof of that one, and the medial wall is formed by the septum pellucidum along with the fornix. Okay? Yes. And now welcome to the most important thing, the floor. Guys, make a note of one thing in your books there. Whatever ventricle you study, the floor of the ventricle will be very much important. So whether it is lateral ventricle or third ventricle or fourth ventricle, the floor of every ventricle will be important. Welcome here. Now, in this lateral ventricle, you are able to appreciate one thing here. This will be the caudate nucleus here. And just beneath here, this will be the thalamus here. So, the caudate nucleus and the thalamus. And between the caudate nucleus and thalamus, there will be a vein, and that is known as the thalamostriate vein. I'm just writing as TS there. Thalamostriate vein. Thalamostriate vein, guys. So, there will be a caudate nucleus, then there will be thalamus. Between them, there will be thalamostriate vein. And I'll just zoom in this one here more. Now, if you are able to appreciate there, inside you will be able to see that there will be network of capillaries, that is nothing but choroid plexus. There will be network of capillaries here, that is nothing but choroid plexus here, guys. Okay. So, all that, I repeat again, the caudate nucleus, the thalamostriate vein, the thalamus and choroid plexus, all of them are going to form the floor of the lateral ventricle. And then the fornix and the septum pellucidum here, these two are going to form the medial wall of the lateral ventricle, and the roof of the lateral ventricle is formed by the corpus callosum, guys. I repeat again for the last time, the roof is formed by corpus callosum, medial wall is formed by septum pellucidum and fornix, and the floor is formed by caudate nucleus, thalamostriate vein, thalamus and the choroid plexus. Okay, that will be the boundaries of lateral ventricle, crystal clear in this diagram. Now, apart from this, my dear friends, you are able to appreciate here that there is a lentiform nucleus here. Beautiful lentiform nucleus here, guys. I hope you have all learned during the regular classes the chordate nucleus, lentiform nucleus, they are a part of your basal ganglia. Fine. Now between these, you will be able to appreciate here that there is some white matter here. The white matter, bundle of axons, the bundle of axons passing from here, that is your white matter fibers here. And that is actually referred to as your internal capsule. What is this one here, guys? Internal capsule. I'll just write down here as IC. Internal capsule. Now, the moment you look at my diagram here, you are easily able to appreciate the relations of internal capsule. Now, look at the diagram there and try to tell what is present lateral to internal capsule, guys. What is present lateral to internal capsule? Lateral to internal capsule will be the lentiform nucleus here. And what is there on the medial? Medial to internal capsule will be having the chordate nucleus and the thalamus, the chordate and thalamus. So, chordate and thalamus, no need to mug up at all. The chordate nucleus and the thalamus are present forming the medial relation of internal capsule, and lentiform nucleus is the one which is going to form the lateral relation of the internal capsule there, guys. Perfectly done. And now, my dear doctors, Dr. Mohan Kumar is asking where is choroid plexus. Mohan Kumar, actually this is a cadaveric image, and in the cadaveric image I can't show you that red colored one, capillaries and all. If you are able to appreciate here, this one, you are able to see here, this will be the choroid plexus here. Choroid plexus is like a network of capillaries there. So, normally in the textbook images, that will be mentioned like a red colored, but this is not like the textbook image, this is cadaveric image, and that is what is trending nowadays, Mohan Kumar. Okay, so try to learn that. And now, my dear doctors, because we are discussing about internal capsule, okay. So, in this coronal section, we have discussed like many points, and now coming to internal capsule, I want to show you one of the important clinical correlation here. And that is about the tracts passing through internal capsule. Many a times the question has been asked regarding this one. So let us see like what are the tracts passing through internal capsule, and then I will tell you what is the importance of that one, guys. So this one here will be the internal capsule here. There will be anterior limb, and then there will be posterior limb, and the bent in the middle will be genu. And then here, this will be the lentiform nucleus towards the lateral side. Now, why I am showing you this lentiform nucleus here? Why? Because the posterior limb will be up to the lentiform nucleus. So, till wherever you have the lentiform nucleus, till there it is posterior limb. Then what about the part behind that one? This is retrolentiform part. Retro behind the lentiform. Retrolentiform part. And then, my dear friends, below here you will be actually having the sublentiform part. So, how many parts do you have in the internal capsule? First, learn the parts of the internal capsule, totally 5 parts. There will be anterior limb, then the genu, then the posterior limb, then retrolentiform part and sublentiform part. Now, all the students who are actually preparing for the NEET PG exam in September, please listen this very carefully. Now, what are the tracts which are going to pass through internal capsule that you have to at least know, Now, there is one tract which is going to pass through the genu here, and that will be the cortico-nuclear tract. Cortico-nuclear tract is going to pass through the genu part. It was a direct MCQ given in the NEET PG exam previously. Previously, it was given in the NEET PG exam. So, that is the reason why I am even taking up this topic here, so that we are going to cover like multiple things here. So, cortico-nuclear tract is the one which is going to pass through which part, guys? Genu part. Then apart from that, there will be one more tract which is going to pass from the posterior limb, and that will be the cortico-spinal tract. Cortico-spinal tract. And this question was actually asked in the AIMS exam. Now, this cortico-spinal tract, we know very well it is going to pass through which limb? Posterior limb. But in the exam, they have given anterior 2/3 of posterior limb, anterior 1/3 of posterior limb, posterior 2/3 of posterior limb, posterior 1/3 of the posterior limb. Are you understanding me? So, all the 4 options are posterior limb only. So, therefore, you have got to remember here, it is passing through anterior 2/3 of posterior limb. The corticospinal tract or the pyramidal tract is the one which is going to pass through anterior 2/3 of the posterior limb. That's extremely important. Now listen to me very carefully here. The clinical correlation. Guys, try to understand what is the meaning of corticonuclear tract. Corticonuclear means what? It is starting from the cortex and it is actually going to supply to the nuclei. Which nuclei? The cranial nerve nuclei. Cranial nerve nuclei. And almost all your cranial nerves are going to supply to which part only? They are going to supply to your head and neck part. Except for the vagus nerve. Vagus is the longest cranial nerve. It is going to travel further. No? But most of your cranial nerves are supplying to which part only? It is supplying to your head and neck part only, guys. So corticonuclear, from the cortex to the nuclei. Which nuclei? Cranial nerve. Cranial nerve will be supplying to what? The head and neck part. That means the genu part is the one where your head and neck is represented. Genu part is the one where the head and neck of the person is represented there, guys. And what about the corticospinal tract? From the name itself, we can understand the corticospinal, cortex to the spinal cord, pyramidal tract. And pyramidal tract is descending, it is going to supply to the muscles, controlling the movements of that one. So therefore, why I have drawn like 3 bundles there? Why? Because, yes, the 3 bundles there. Why? Because the first bundle of fibers are going to supply to your upper limb there, and the second bundle there, that is corresponding to your trunk region, and the third bundle there, that is corresponding to the lower limb. Oh my God, that is in the same sequence. That's in the same sequence, sir. So upper limb, the trunk, and the lower limb. Upper limb, the trunk, and the lower limb, guys. Okay. So therefore, my dear friends, you can observe there, oh my God, our entire body is represented in the internal capsule. Any damage to this one, any injury or any lesion to this one here, there will be widespread effect in our entire body, sir. Widespread effect in our entire body. Understanding? That's the reason why they are going to test you this one in the exam, guys. So what is the tract which is going to pass through genu part here? Corticonuclear. And what is the tract passing through the anterior 2/3 of the posterior limb? That is nothing but the corticospinal tract, and your entire body is represented. And where do you have all this bundle of fibers here? All this bundle of fibers you are able to appreciate here. That's your internal capsule. Hope it is perfect. So as promised, delivered. We have covered the concept here. We have discussed the image based questions here. You are able to identify every structure in this image here, as well as the clinical correlation. So I hope you are able to utilize the time here and all the topics are getting refreshed, guys. Thank you. Thank you, Dr. Subrasmita Bhoi. Dr. Bhoi, thank you. Yes, Dr. Jinesh, I'm good. I hope you're also doing good. Yes, I do remember. I have been a lot of time to Ahmedabad, Gujarat there. Thank you. Thank you, Jinesh Wagela. Chaliye, let us go to the next concept right now, guys. After this, let's go to the next concept now. Now, after this, I want to discuss about the tracts and the lemnisci. And that will be actually related to your brainstem syndromes. And this is the place where I have seen like many students actually getting confused, guys. Let me try to clear this confusion. So observe this very carefully. And I am trying to show you this in a different pattern here, guys. Not like the same way as we discussed in our regular classes and all. So during this quick revision program, let us try to discuss about the tracts and the lemnisci in the easiest manner possible in one single diagram. And I request all of you to please draw the diagram with me. Guys. Now, if you people have attended my regular class, you know this section very well. This will be the cerebral hemisphere here and the cerebral hemisphere on the other side. Followed by there will be diencephalon, which is made up of all thalami parts. All the thalami parts together going to form diencephalon. Then followed by that, you'll be having your midbrain, and then the pons, the medulla oblongata, and then followed by that you'll be having your spinal cord. So that is like coronal section here, and that is actually the schematic diagram of the coronal section, guys. Okay. Now welcome to the spinal cord here. In the spinal cord, let us draw the diagram of the transverse section of the spinal cord, and you're all like experts in this one. There will be posterior median sulcus, then the fissure, and then you'll be having that H shape or butterfly shape gray matter with the central canal. In the center, try to draw the imaginary line so that we'll get to know whether the tract is crossing or not crossing. Guys, I request all of you with folded hands here, please try to draw it with me. At the end, you'll be getting a beautiful conclusion. Please try to draw it with me. You'll be getting a beautiful conclusion at the end. Yes, Dr. Sunaina, I will tell you. Yes, Dr. Sunaina, I'll tell you about that one. Don't worry. how to attend your regular classes. Dr. Monil Shah, welcome to Doc Tutorials app. Yes, you can find all my videos here in the recorded format. Now, my dear doctors, listen to me very carefully for the next 10 to 15 minutes. At the end, I'll give you a beautiful conclusion and you'll be able to solve like many MCQs here, sir. You will be able to solve like many MCQs here. Listen to me very carefully here, guys. Now, in the spinal cord, actually you'll be having the white matter, and the white matter wherever you have, that is nothing but your columns. In the spinal cord, you'll be having like 3 columns: dorsal column, ventral column and lateral column. Dorsal column, the ventral column and the lateral column. Now, in the dorsal column, we have only ascending tracts. In dorsal column, we'll be having only and only ascending tracts. Now, there are certain fibers which are coming from the lower limb. And these fibers are going to enter from the dorsal root here, and there is a ganglion. That ganglion is known as dorsal root ganglion. Guys, because we are just doing the revision here, I'm not going to write down every name there. So I hope you'll be able to write down along with me. So there are certain fibers coming from the lower limb. These fibers will be going to enter from where? From the dorsal root. Okay. And from the dorsal root, these fibers are going to enter from here via the dorsal root ganglion here. And after entering here, they are going to continue from the dorsal column. And if these fibers are coming from the lower limb, definitely it is going to form which tract? Fasciculus gracilis. If these fibers are coming from the lower limb, they are going to form which tract only, sir? Fasciculus gracilis. Yes, fasciculus gracilis, guys. Now the next one here, there are certain fibers coming from the upper limb, and those fibers are also going to enter from where only? From the dorsal root ganglion. And after entering here, are they going to stop? No, they will continue up. And remember, if they are coming from upper limb, definitely that is going to form your fasciculus cuneatus. Let me just highlight with the same color code here. Wow. So already we have learned like many points here. The fibers which are coming from the lower limb, those are the one which are going to form fasciculus gracilis. From the upper limb, those are the one which are going to form your fasciculus cuneatus. Now, appreciate one important thing there. Are they crossing the spinal cord? No. Are they stopping in the spinal cord? No. They are going to stop where? They are going to stop in medulla oblongata. And in the medulla oblongata, they stop in the respective nucleus. I mean to say, fasciculus gracilis will end in the gracilis nucleus. Fasciculus cuneatus will end in the cuneatus nucleus. And where do you have these two nuclei? They are in the medulla oblongata, crystal clearly in my diagram here. So gracilis nucleus and the cuneatus nucleus, both of them are present in the medulla oblongata. Okay. Now what is going to happen here? Are they going to stop here? No. From this, another second order neuron, they are going to cross. And after crossing, they are going to ascend up in medulla oblongata and the pons and the midbrain. I mean to say in the brainstem. The fibers are going to cross and they are going to ascend up. Now these fibers which are crossing there, yes, remember them. Why? Because they are crossing in which part of the brain? Medulla oblongata. Oh, that means crossing is taking place in which part of the brain, sir? Medulla oblongata. And those fibers are like arch-like. That is why they are known as internal arcuate fibers. What are these fibers known as? Internal arcuate fibers. And yes, welcome here, Dr. Sunena. Welcome here, Dr. Sunena. When these fibers are crossed, those second order fibers, and they are ascending up in the brainstem, the midbrain, pons and medulla, there it will be referred to as lemniscus. And this lemniscus will be the medial lemniscus. So in simple words, what I can tell you here, until and unless it is present in the spinal cord, जब तक वो spinal cord में होगा ना डॉक्टर सुनैना, until unless it is in the spinal cord, उसको हम tract कहते हैं. It is known as tract. But the moment it enters into the brainstem, from the spinal cord, जैसे वो brainstem में आएगा, medulla, pons and midbrain, उसको हम lemniscus कहते हैं. Simple thing. That is known as lemniscus. That's your medial lemniscus. Now, where is this medial lemniscus going and ending? Look at my diagram. That is diencephalon. And in diencephalon, it is made up of all the thalami. So, therefore, it will end in thalamus. Any point to remember here? Yes, of course. It is ending in VPL nucleus of thalamus, the ventral posterolateral nucleus of thalamus. Yes, Dr. Zenif, dorsal column, medial lemniscus system. So it is ending where, guys? In the VPL nucleus of thalamus. Now, will the fibers stop here? No. From here, another fibers are going to radiate from the thalamus, and these fibers are all the way going to the cortex here. And of course, which part in the cortex? Sensory area. Which cortex, guys? The sensory cortex. Ascending tract is going to carry the sensory information. So you don't even have to even mug up this one here. Ascending tract will carry sensory information. That will be taken to which area only? The sensory area. Area number 3, 1 and 2. Area number 3, 1 and 2. Lovely. Is there any name for these fibers here? Yes, of course. These fibers are referred to as thalamic radiations, because they are radiating from the thalamus. That is thalamic radiations, guys. Lovely. So the entire tract is actually done in 5 minutes here. So fasciculus gracilis and cuneatus is done in 5 minutes. Done. Now what I am trying to do here in this quick revision program here, welcome here for the very first time. Hello, my dear friends. Achha, one more thing. We have actually not written the functions. What are the functions of these two tracts? What are they going to carry? We have seen the anatomy part. We have traced the entire tract, but what is their function? Fasciculus gracilis and cuneatus, they are the one which are going to carry the fine touch. Very important. Number 2, they are the one which are going to carry the vibration sensation. And not only that, even stereognosis. I hope you all know about stereognosis. Ability to identify the object just by touch. Okay. Ability to identify the objects by just touch. Okay, now without seeing, no visual identification. And after that, not only that, even proprioception. And which proprioception, guys? Conscious or unconscious? Remember, they are going to carry the conscious proprioception. Yes, it is obviously going to the highest center, the cortex there. So therefore, it is the one which is going to carry the conscious proprioception. So fine touch, vibration, stereognosis and proprioception, that to conscious, it's all carried by fasciculus gracilis and cuneatus, guys. Lovely. Now welcome here, guys. Let us try to include one more thing here. Again, draw the transverse section of the spinal cord. Posterior median sulcus, anterior median fissure, and then there will be H shape or butterfly shape gray matter. Listen here. I want to correlate this at the end with the clinical correlation, guys. So listen carefully here. Another 5 minutes. Now there are some more fibers which are going to enter from here, the dorsal root ganglion, and these fibers will enter here and they'll end here, the first order neurons. And these are the fibers which are going to carry what? They are the one which are going to carry the pain, and then the temperature, and then the crude touch and pressure. So pain, temperature, crude touch and pressure, this is going to enter via the dorsal root ganglion. And yes, they will enter via the dorsal root ganglion, and after entering via the dorsal root ganglion, these fibers are going to end there, guys. Okay, these fibers are going to end there. वो वहाँ पर end हो जाते हैं. Now after ending there, another fibers are going to begin from here. I request all of you to please listen to this very, very carefully here, guys. Dr. Desai, thank you, Dr. Desai. Yes. Now after ending here, now another fibers are going to begin from here. Now some of the fibers are going to cross on the other side. And they are the one which are going to become your lateral spinothalamic tract. They're going through the lateral column, and that is going to become what, guys? The lateral spinothalamic tract, one of the most important tract and the very, very, very important and very famous tract. Now from there, some of the fibers are going to cross to the anterior column, and from the anterior column they are going to ascend up, and because they are ascending from the anterior column, that is referred to as the anterior spinothalamic tract. Wow. And now, my dear friends, listen here very, very carefully. The dorsal root ganglion fibers are entering there and they are stopping, they are ending there, and from there another fibers are going to begin. That means there is a junction, there is a relay. And wherever there is a junction here, this relay here, that's extremely important point. Why? वहाँ पर decide होता है. Listen to me very carefully. There it will be decided which impulses will be going where, guys. Okay. Out of this, remember, the pain and temperature will be going where the lateral spinothalamic tract. Whereas the crude touch and pressure, it will be going through the anterior spinothalamic tract. Crude touch and pressure will be passing through the anterior spinothalamic tract. Understanding? So let me give a different color code here, guys. The pain and temperature is going through the lateral spinothalamic tract, and the crude touch and pressure, it will be going through the anterior spinothalamic tract. Is it okay? Understanding here? And where it will be decided? It will be decided right at the place where there is that junction, guys. That's the reason why that is very much important here. Where is that relay? Where is that junction, guys? ये relay कहाँ हो रहा है? That place is very much important, and that has been asked a lot of times in your exams, and that is known as what here? Substantia gelatinosa. This is known as the substantia gelatinosa. That a relay station, that place is actually known as the substantia gelatinosa there, guys. Okay. Now my dear friends, let's go ahead. Now what is going to happen? Yes, I told already Dr. Sunaina that now these tracts, until and unless they are present in the spinal cord, they are known as tract. And now these are going to ascend up into the brainstem. The moment they enter into the brainstem, now it is known as what? It is known as the lemniscus. है ना? So therefore, my dear friends, welcome here. The lateral spinothalamic tract, it is the one which is going to form lemniscus, and that lemniscus will be the spinal lemniscus. So spinal lemniscus is actually the continuation of yes, the lateral spinothalamic tract. And whereas the anterior spinothalamic tract, this will actually just go and join with the medial lemniscus. I hope it is crystal clear. Anterior spinothalamic tract will actually go and join with the medial lemniscus. I hope it is very clear, guys. Why? Because God has made our body in such a way that, look at the beauty, guys. God has made our body in such a way that whether it is crude touch or whether it is fine touch, yes, all of them has to finally go from where only? Yes, all of them will finally has to go from where only, guys? They have to go from the medial lemniscus only. Understanding? The fine touch or the crude touch, both of them are actually going through the medial lemniscus only, guys. Perfect. Yes, Dr. Nivedita, I hope it is perfect right now. समझ में आ रहा है? Very good, Dr. Akhil Ansari. तो आगे बढ़ते हैं सर. And now you might be thinking कि my goodness, this picture we have never seen in the notes, है ना? This picture we have never seen in the notes also, in my anatomy notes and all. Yes, this is exclusively for the quick revision program. Why? Because we don't have much time right now while you're preparing for your exam. So I don't want to deal in like different pictures, and this will also give you a perfect concept here. It will give a perfect concept, guys. So it's like welcome to like Dr. Azam 2.0. Understanding? Yes. We are going to deal with all the clinical things now from here onwards. So 2021, then 2022, then slowly we are moving towards the next exam and all. So now it's all going to change, guys, with the clinical anatomy and everything. Anatomy correlated with surgery and the medicine as well as the orthopedics and all. Ab yahan suno sir, listen here. After learning all this, welcome to the final conclusion. Lemniscus. Okay, 4 of them. Listen this one, sir. Very important. Listen this one. Yes, a lemniscus here, guys. Okay. Now, in the lemniscus, totally 4 of them. Number 1 lemniscus that you are able to see on the screen there, spinal lemniscus. And now I want the answers from you. After attending this class here, you will be able to even correlate this with the medicine. the brainstem syndrome. Now you can even correlate, yes, even correlate this with the brainstem syndromes. मान लो, okay, you have taken a transverse section along this midbrain or the pons or the medulla oblongata. And when you take a transverse section, guys, here, now for example, you just imagine that there is injury to, yes, there is injury to this spinal lemniscus, guys. Spinal lemniscus is actually the continuation of lateral spinothalamic tract. And lateral spinothalamic tract, it is the one which is going to carry pain and temperature. Therefore, if there is any injury to the spinal lemniscus, come on guys, tell me. If there is any injury to the spinal lemniscus, then what is going to happen? There will be loss of pain and temperature. इसी के लिए तो मैं आपको ना इतना क्लियरली बता रहा था. That is the reason why I was telling you like so clearly from that time. Listen to the climax of the story now, the conclusion here. If there is an injury to that one, then what will happen? There will be loss of pain and temperature. Ipsilateral or contralateral? I want the correct answer from all of you right now. I'm waiting for your answers. Yes, I'm saying here. My goodness, I'm really happy with Dr. Prajwal there. Dr. Prajwal, yes, there will be contralateral loss of pain and temperature. Yes, there will be contralateral loss of pain and temperature from body. That's important. I'll tell you the reason why. There will be contralateral loss of pain and temperature from the body. Yes, lovely, Dr. Medico, lovely Zenef, lovely Prithviraj, very nice. Now you are able to tell like with very much confidence right now, guys. Now similarly, for example, if there is an injury to this medial lemniscus, if this medial lemniscus is gone, then what is going to happen? If the medial lemniscus is gone, then it is the one which is going to carry fine touch, vibration, stereognosis, proprioception, everything. So now you only tell me, number 2, medial lemniscus, if it is gone, then what is going to happen? Again, there will be contralateral loss of all that things, fine touch, blah, 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 blah. I'm not writing all of them. Fine touch, the vibration, proprioception, conscious proprioception, and all those guys. Lovely. Now, after that, my dear friends, not only these 2 lemniscus, you'll be having number 3 lemniscus, the third one. Okay. This NEET PG exam, clinical questions are going to come. So please listen to me very, very carefully. I think I'm trying to make the things very, very much simple here, guys. Okay. So now tell me, guys, next one. The next one will be the lateral lemniscus. Medial lemniscus, then you also have lateral lemniscus. But sir, we did not study about the lateral lemniscus here. It comes in your auditory pathway. You remember auditory pathway? One of the mnemonic for that very famous one, E. coli ma. In that auditory pathway, you are going to come across the lateral lemniscus. So if there is an injury to that lateral lemniscus, then what is going to happen? Again, contralateral loss of hearing. Hearing. It comes in auditory pathway. And then number 4, my dear friends, will be the trigeminal lemniscus. And trigeminal lemniscus, you people know very well, trigeminal nerve is the one which is going to carry all the sensations from your face, the pain, temperature, touch, pressure, everything from the face. So therefore, my dear friends, if there is any injury to that one, then again what will happen? Contralateral loss of pain and temperature, but from face. Oh my God. Are all the lemnisci crystal clear today? Or all the 4 lemnisci like crystal clear today, guys? Spinal lemniscus is the continuation of lateral spinothalamic tract, loss of pain and temperature from the body on the screen there. Medial lemniscus, loss of fine touch, vibration, stereognosis, proprioception, yes, contralateral. Lateral lemniscus is a part of your auditory pathway, so contralateral loss of hearing. And then trigeminal lemniscus, trigeminal nerve will be the one which is going to carry all the sensations from your face. That is why loss of pain and temperature from the face. And my dear friends, one conclusion I want you to keep in your mind today itself, that whenever you hear the word as lemniscus, involvement of lemniscus, when you study about the brainstem syndromes, when you study about this brainstem syndrome, whenever you listen the word of lemniscus, close your eyes and the answer has to be always contralateral. Because lemniscus is always formed after crossing only. That is one beautiful conclusion, guys. One beautiful observation I'm telling you there. Lemniscus is always formed after crossing only. That's the reason why in the exam, if you see any brainstem syndrome where lemniscus is involved, don't try to have a confusion in your mind कि यार ipsilateral होगा, contralateral होगा, ipsilateral, contralateral. No, it will be always contralateral loss. Always contralateral loss. Okay, so that is about that. So I have actually given you the basic foundation stronger now. And now in the medicine or in pathology, wherever you learn about the midbrain syndromes, when you take a transfer section here, the midbrain or the Pontine syndromes or medullary syndromes, you can clearly see the lemnisci passing from there, and you can easily apply that concept in the medicine and pathology, guys. Are you understanding here? So anytime when you learn about the midbrain syndromes or the Pontine syndromes or the medullary syndromes, I have given you the basic foundation crystal clearly in your mind, guys. And now you can easily apply that concept to your medicine and pathology everywhere. Is it okay? I hope you're happy with this one here. So in this one concept, guys, everything has been completed, like all the tracts and the lemnisci, the clinical correlation, everything is done and done and done, guys. Okay. Thank you, Musharraf Ali. Chaliye ji. So it's like, concise diagram of all the tracks over there. Now, next concept, let us go towards the next concept here, guys. Please try to read this question now. Thank you, Dr. Bushra and Anwar. Thank you, Dr. AB. Now, try to read this question here right now, guys. A 67-year-old woman is evaluated for frequent fainting spells. A carotid duplex ultrasound reveals significant narrowing of the right internal carotid artery. And then moderate narrowing of the left internal carotid artery. In order to access the internal carotid artery, the surgeon has to enter a sheath that also contains other structures. Thank you, Dr. Dami. Thank you, everyone. Yeah, welcome here. Now, yes. So, internal carotid artery is actually present there. Along with that, what are the other structures? So, where do you have the internal carotid artery? It is basically about the carotid sheath. Very good. Very nice. Okay. So, basically, the question is about the contents of carotid sheath. So, instead of asking directly, you can see how the clinical question can be framed. How the clinical question can be actually framed, guys. Now, why I have included this concept here or this question here? Why? Because your NEET PG examiner is very much interested about the transverse section of the neck and the deep cervical fascia. The transverse section of the neck and deep cervical fascia. Many a times there will be a question regarding this fascia. Let's deal with them one by one, guys. Now, once you take a transverse section of the neck over here, yes, my dear friends, there will be one fascia over here, which you are able to see in red color. And this fascia is like, present throughout the neck, and it is enclosing two important muscles. It is splitting and enclosing. Number one, sternocleidomastoid muscle here. And then there will be trapezius muscle over here. And this is actually known as the investing layer. This is investing layer or the investing fascia. Then apart from that, you are able to see this one, the blue colored one, the fascia, which is around the thyroid gland. And it is right in front of the trachea. So therefore, this is known as the pretracheal fascia. And this yellow colored one or the orange colored one, which is surrounding the cervical vertebrae and the muscles over there, it is known as the prevertebral fascia. And then finally, this one here will be the carotid sheath. That is carotid sheath. Now, whatever these four modifications I have written here, all these four modifications are the modifications of deep cervical fascia. The deep fascia of the neck, sir. The deep cervical fascia or the deep fascia of the neck. Fine. So deep cervical fascia has got these modifications. Number one, there will be investing layer. Number two, you'll be having the pretracheal fascia. And number three, there will be the carotid sheath, and then you'll be having the prevertebral fascia here. Fine. Now, out of this, for your NEET PG exam, the carotid sheath is extremely important here, guys. Recently also, they have asked the contents of the carotid sheath. Now, what do you have inside the carotid sheath? Carotid sheath के अंदर क्या होता है? What are the contents of the carotid sheath? For example, if I just draw the carotid sheath here in the longitudinal section, instead of transverse section, let me draw it in the longitudinal section here. Now remember, first of all, there will be a common carotid artery entering inside. That will be the common carotid artery, and that will give rise to a branch, that is external carotid artery coming out, and this common carotid will continue as your internal carotid artery. Then what is a vein which is going to drain the blood from there? That is your jugular vein. So that will also consist of internal jugular vein, the carotid artery, and then internal jugular vein. Between these two, the sandwich between these two will be having the nerve, and that is your longest cranial nerve, and that will be the 10th nerve, the vagus nerve. The 10th nerve, vagus nerve. Perfect. So what will be the contents of the carotid sheath? Number one, I can clearly see in the diagram here. Number one, common carotid artery. Number two, internal carotid artery. Number three, the vagus nerve. And number four, the internal jugular vein. 4 contents. Every medical student is perfect with this one right from first year MBBS. Carotid sheath will consist of common carotid artery, internal carotid artery, the vagus nerve, and the internal jugular vein. Fine. But listen to me very carefully now. In the NEET PG exam, what was given recently? Guys, do you remember jugular foramen? We have already discussed that in the head and neck topic. In head and neck topic, all the cranial foramen, foramen rotundum, ovale, jugular foramen and all. So jugular foramen is the one from where the 9th, 10th and 11th cranial nerve is going to pass. So try to understand here at once. For example, if this is jugular foramen here, and from the jugular foramen, the 9th, 10th and 11th nerve is going to pass from here. 9th, 10th and 11th. And just beneath that, from the base of the skull, just beneath that, your carotid sheath is actually going to begin. From the base of the skull into the neck region here, the carotid sheath is going to come down. Try to correlate now. So if the carotid sheath is coming from there only, then how come it will have only the vagus nerve? Along with the 10th nerve, even the 9th and 11th is also present there only. Are you understanding my point here? So therefore, my dear friends, remember, you will also have the 9th as well as the 10th cranial nerve, but the problem, the panga here is that they are not going to travel throughout the carotid sheath. They are actually just going to be present in the upper part of that one. I'm just drawing a schematic diagram here. The 9th and the 10th and the 11th nerve. So they are going to just enter into the carotid sheath and exit out. Only in the upper part. Only in the upper part. You also have got the 9th nerve and the 11th nerve. And in the recent NEET PG exam, whatever feedback we got from the students, yes. Remember, my dear friends, they have given in the exam, in the options, even 9th nerve was given. Is it a content of carotid sheath? Of course, it is also a content of carotid sheath. Understanding? So please include there, update there. The content of this one will be common carotid artery, internal jugular vein, along with the 9th nerve and the 10th nerve. Even the 11th nerve is also a content of the carotid sheath. Lovely. I hope now you are understanding the correlation. The jugular foramen is the one from where 9, 10, 11 is going to pass, and from there itself the carotid sheath is going to begin. So therefore, my dear friends, remember 9th and 10th and 11th, all of them are the content of your carotid sheath. Lovely. Awesome. That is one important concept I wanted to teach you here in the quick revision program. You should know about that. Why? Because carotid sheath is one of the hot favorite question of your MC examiner. And yes, there are chances that it can be even asked in the form of a clinical question here. So in order to access the internal carotid artery, the surgeon has to enter a sheath. That sheath will also contain external laryngeal nerve, no. External jugular vein, no. Vagus nerve, yes, it is also present inside that. External carotid artery, no. It will immediately exit out, guys. It is not a content. Now, apart from that, I want you to, yes, even learn some of the nerves here, guys. I will try to mark here. You try to identify this one here, guys. Can you please tell me what is this nerve over here? For example, today is the exam. Today is 11th September and you have your screen in front of you. And on the screen, yes, identify the arrow marked nerve. This nerve is present inside the carotid sheath. Definitely it is your 10th cranial nerve, vagus nerve. Now after that, identify what about this one here right now. That is present behind the carotid sheath. And what is the posterior relation of the carotid sheath, sir? Posteriorly, we will be having sympathetic trunk. Carotid sheath, behind that one, you will be having the sympathetic trunk. That is the posterior relation of that. I am really happy with the answer that you are giving there, guys. Lovely. Now, once you see inside here, inside the prevertebral fascia, you are able to see the vertebrae, the transverse process. Attached to that, you will be having your scalenus anterior muscle. And this one here will be the scalenus medius muscle. The scalenus anterior muscle, and then there will be scalenus medius muscle. Lovely, lovely, lovely. Now, between the scalenus anterior and the scalenus medius also, you are able to see that there is a nerve. And that one has to be definitely your brachial plexus. We have been learning from the first year MBBS that brachial plexus is the one which is going to pass between the scalenus anterior and medius. No, 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 no. Dr. Prithviraj, Dr. Batman, it's not phrenic. That's why I'm telling you so clearly there. Between scalenus anterior and the medius. No, no, Dr. Prajwal. Between scalenus anterior and medius, there will be brachial plexus. Remember, phrenic nerve is the one which is present anterior to scalenus anterior muscle. That is how you have to identify. In front of scalenus anterior, what do you have here, guys? That's your phrenic nerve. इसी के लिए तो मैं आपको पढ़ा रहा हूँ. That is the reason why I am teaching you here this one in the quick revision program at Doc Tutorials. Welcome. Okay. So what do you have right in front of the scalenus anterior muscle? Scalenus anterior muscle के सामने, in front of that one, you'll be having the phrenic nerve. And between the scalenus anterior and the medius, there will be brachial plexus. That is how you have to identify that one, guys. Lovely. And then yes, this is trachea here, and just behind the trachea, there will be esophagus here, and there is a groove. That groove is known as tracheo-esophageal groove. Tracheo-esophageal groove. And in that groove, you are able to appreciate one more nerve there. That will be the recurrent laryngeal nerve. That is the recurrent laryngeal nerve. Oh my God. There are like so many nerves there, and it should be like perfect with this one here. That's the reason why I have included the transverse section of the neck in this quick revision program session, guys. Lovely, done. Okay. So that is all about this one here that I wanted to actually revise for you people. Let us go to the next concept now. Expecting this type of question to be in the next NEET PG exam, sir. In the next NEET PG exam on 11th September, I am expecting this type of question to be asked, okay, or this concept to be asked in the exam. Look at this very, very carefully. A 60-year-old female presents to the emergency room with the nausea and epigastric abdominal pain. There is a epigastric pain here, sir. There is epigastric abdominal pain. She has been experiencing abdominal discomfort for months. However, in the last few weeks, the pain has gotten progressively worse. Now radiates to the back also. She notes no specific trigger for the pain, though does appreciate temporary relief following meals. There is a relief following the meals. After taking antacids. Oh, it is referring to somehow the ulcers. She has also darkening of her stools, denies frank blood. On examination, her abdomen is soft and non-distended, tender to palpation in the epigastric region. And then finally, the peptic ulcer of the posterior abdominal wall. Finally, we have found that there is a peptic ulcer of posterior abdominal wall. if this ulcer perforates, which structure is at the risk of damage? Okay, which artery will be at the risk of damage? Okay, तो चलिए देखते हैं sir. Let's see here. Dr. Kiran is actually asking, sir, how many hours will be this class here? I think this will be for another few minutes, Dr. Kiran. Like many of the concepts has been done here, or otherwise we can continue with the session for as much as time as you want if you people are interested. So now in this, let us try to draw the diagram here, and I'll keep on drawing the diagram and you people try to identify. Why? Because now you're already prepared for your exam. Hardly few days are left out, 10-11 days. So I'll draw the arteries here, you try to identify. Okay, so esophagus, stomach, and this one is your duodenum here, first part, second part, third part, and the fourth part. Now in this C-shaped concavity here, you'll be able to find the pancreas, and the pancreas, we all know it is going to go behind the stomach. It is a stomach bed relation, and the tail of the pancreas will be actually lying in the hilum of the spleen here. So there will be spleen here, guys, just try to understand. And if that is the stomach towards the left side, yes, now we have got the liver placed towards the right side, guys. So let us draw the diagram of the liver towards the right side here, and attached to that or along with that, we'll be having the gallbladder. And now, my dear doctors, towards the left there will be stomach here, and towards the right there will be, yes, the liver there, and in the middle you'll be actually having your celiac trunk. That's the hero of the story. That's your celiac trunk, which will be given at the level of T12. Celiac trunk given at the level of T12. T12. Thank you, Philip. Okay, Dr. Saini, no problem. Yes. And now that is your celiac trunk. I'm not drawing the abdominal aorta and all those, guys. मैं वहाँ पर abdominal aorta draw नहीं कर रहा हूँ. I'm not drawing there. Try to understand. Abdominal aorta will give 3 ventral branches: celiac trunk, superior mesenteric artery, and inferior mesenteric artery. Out of that, imagine this one to be the celiac trunk. And now start telling me about the branches. I hope you all know very well that celiac trunk is going to give rise to 3 major branches. Yes, celiac trunk is actually going to give rise to how many major branches? 3 major branches. And out of the 3 major branches, number 1, you'll be having the left gastric artery. That is the easiest one. This is left gastric artery. And on its way to the lesser curvature of the stomach, it will be actually giving the branches to what? To the esophagus, and these branches are esophageal branches. Esophageal branches, guys. That's done. Okay, left gastric artery is completed here. Now, number 2, the second major branch, the second main branch of celiac trunk will be splenic artery. And splenic artery, will it go in front of the stomach or behind the stomach, guys? It will be going like behind the stomach, and finally it is going and supplying to the spleen there. This is your second major branch of the celiac trunk, that is splenic artery. And yes, my dear doctors, why am I drawing that in that zigzag manner? Why? Because splenic artery is the one which will be like an example of, tortuous artery. It is an example of tortuous artery behind the stomach, and it is tortuous. Now on the way, look here, sir, how beautifully we can remember the names of the branches now. On the way, it will be giving the branches to the pancreas, pancreatic branches. Then it will also give a branch along the greater curvature, and that one will be the left gastroepiploic artery. Gastro means to the stomach, epiploic means to the omentum, left gastroepiploic artery. And then it will also give like small branches near the greater curvature of the stomach, that is your short gastric artery, near the fundus, short gastric artery. And then it will also give like many branches in the hilum of the spleen, and these are known as the hilar branches. So splenic artery, while going to the spleen, on the way it will be giving the branches to the pancreas, pancreatic branches, and then left gastroepiploic artery along the greater curvature, short gastric arteries near the fundus, and then the hilar branches. Done. And now, my dear friends, welcome here. The last and final, the third main branch, the celiac trunk will also give one more main branch here, that will be the common hepatic artery. And common hepatic artery will be actually dividing into two branches, one which is actually going towards the liver, proper hepatic artery, and then one branch which will be actually going behind the first part of duodenum, and that artery will be the gastroduodenal artery. Look at my diagram. I'm already drawing the diagram very much specifically there. I've drawn in dotted lines. It's going to go behind the first part of the duodenum there. It is gastroduodenal artery. So therefore, I can tell finally that common hepatic artery will divide into two branches. One will be the gastroduodenal artery, another one will be the proper hepatic artery. Out of these two, gastroduodenal artery is very much easier here, guys. It will be giving a branch. It will be giving a branch along the greater curvature here, and that one will be the right gastroepiploic artery. Right gastroepiploic artery, and it'll also give like one more branch here between the pancreas and the duodenum, and that is superior pancreatico-duodenal artery. Superior pancreatico-duodenal artery, guys. Okay, so gastroduodenal artery here will be dividing into two branches, right gastroepiploic artery and the superior pancreatico-duodenal artery. Done. And now welcome to the proper hepatic artery. That's easy. Why? Because it is the one which is going to divide into the right hepatic artery and the left hepatic artery. And right hepatic artery is the one which will be giving a branch to the gallbladder. Gallbladder, it will be cystic artery. Cystic artery. Perfectly done. Is it okay? So that's an easy way to remember here, guys. Okay, Dr. Rajesh Roshan, welcome to the club. Welcome to the club. Sure. I will be glad to teach you. Now look at the diagram very, very carefully, guys. On the lesser curvature, we have got only the left gastric artery, but what about the right gastric artery? On the lesser curvature, you are able to see only the left gastric artery here. What about the right gastric artery? वो किसका branch होगा? It is a branch of which one? Remember, proper hepatic artery. So proper hepatic artery is actually going towards the liver. Before going towards the liver, it is going to give a branch along the lesser curvature, and this branch along the lesser curvature will be the right gastric artery. Right gastric artery. Lovely. Oh my God, look at the diagram there, guys. Okay, so celiac trunk with all its branches, it is the one which will be supplying to the entire foregut. Okay, it is the one which is going to supply to the entire foregut, guys. Now coming back to our question here, there is actually a ulcer, and there is a perforation of that ulcer, and that ulcer कहाँ पर है वो? It is actually here. So we have started this discussion from here. There is a peptic ulcer, and that peptic ulcer of posterior duodenal wall, and that ulcer perforates actually. So which structure will be damaged and bleeding will occur from which artery, guys? The artery which is going to pass behind the first part of the duodenum, that is your gastroduodenal artery. Are you understanding? Gastroduodenal artery, guys. Are you getting my point here, guys? So duodenal ulcer, what is the artery which is going to get damaged there? That is nothing but the gastroduodenal artery. So my dear friends, what I am trying to teach you here in our quick revision program here at Doc Tutorials, what I am trying to teach you here is that in anatomy, I already taught this one. मैंने already पढ़ाया है. In our regular classes already I taught you. But there, the thinking of the people will be like, okay, fine, we have to just learn the artery and its branches. While learning anatomy, our thinking as a student will be, okay, chalo, these are the branches, these are the arteries you have to learn. But what is the clinical application of that one? That is what I am trying to tell you here. Get set ready for your NEET PG exam this time. This kind of clinical questions can be given. So in ulcer, what is the artery that is involved? Yes, that is your gastroduodenal artery, which is going to pass behind the first part of the duodenum. Sorry, gastroduodenal artery, guys. And one thing I want to tell you here, some of the people were telling me about the right gastric artery just now. Guys, there is, I don't know why there is a lot of controversy in this one here. Right gastric artery is a branch of common hepatic, and it is a branch of gastroduodenal, blah, blah, blah. Already I have actually, posted on my Instagram handle the latest edition of the Grey's Anatomy, 42nd edition of the Grey's Anatomy. I have even taken a a screenshot of that one and posted on that one. It's given very clearly in the 42nd edition of Grey's Anatomy that right gastric artery is a branch of, it's a branch of the proper hepatic artery. I don't know, like it might be given somewhere. I have not come across that one, but like most of the students, every time during the live classes also, during the online classes also, most of the students are like confused here. Right gastric artery kiska branch hai? Remember, once for the last and final time, right gastric artery is a branch of your proper hepatic artery. It's given very clearly. If you want a reference, you can just go and refer to the Instagram handle there. I have already posted that one, guys. Okay. So that is about the another clinical condition here. So in ulcers, peptic ulcers, the artery which is involved there will be the gastroduodenal artery. Now moving towards the next concept is about the anterior abdominal wall and inguinal canal. And why I have selected this one to discuss here in the quick revision program here? Why? Because inguinal canal, it will be correlated with the hernia, inguinal hernia, the direct and indirect inguinal hernia, and many a times, many questions will come. And I am sure that in the next NEET PG exam, definitely you are going to get one question based on the hernia, inguinal hernia and all. So based on hernia, definitely you'll be getting a clinical question, guys. Get set ready for this one here. Welcome. Let's go ahead. Now at this point of time when your exam is very much nearby, I hope I don't have to tell you about the anterior abdominal wall. You already know all the layers in the anterior abdominal wall. Now in this, welcome here, point number 1. Transversalis fascia. In the transversalis fascia, you'll be having one oval shaped defect here, and that oval shaped defect is referred to as your deep inguinal ring. So deep inguinal ring is present in which layer, sir? Point number 1, transversalis fascia. Listen to me very carefully, guys. So deep inguinal ring is present in transversalis fascia. Similarly, you also have external oblique aponeurosis here. And in the external oblique aponeurosis, you'll be having a triangle shaped opening here. And this one will be the superficial inguinal ring. So deep inguinal ring is present in which layer? Transversalis fascia. Superficial inguinal ring is present in which layer? That will be in the external oblique aponeurosis. Now join them together. The deep inguinal ring and the superficial inguinal ring, if you just join them together, it will lead to the formation of a canal here, and this canal is referred to as your inguinal canal. Okay, it is nothing but your inguinal canal. Now what you have to do here is that you got to learn about what are the boundaries of this inguinal canal, and let me make all the boundaries of the inguinal canal easy with the help of this diagram here. The diagram on the screen there, that is going to make all the boundaries very much easier. So what you do here is that in this entire diagram, you just focus here on the inguinal canal from here to here. That's the inguinal canal. If you just focus on the inguinal canal, what do you have right in the front here? Right in front of the inguinal canal, you are able to see external oblique here and the internal oblique here. So external oblique and internal oblique, these two are the one which are going to form the anterior wall, the anterior boundary of the inguinal canal. Easy. Then what you are able to see behind, sir, पीछे क्या होता है? Behind you are able to see this fascia here, and that is your transversalis fascia. And then look here very carefully. Let me remove these lines from here. Look here very carefully, guys. Internal oblique aponeurosis is arching from above and going on the other side. Internal oblique aponeurosis is going on the other side. And similarly, transversus abdominis muscle aponeurosis is also arching above here and going on the other side. I repeat again, internal oblique and transversus abdominis. These two aponeuroses are arching and going on the other side and joining to form, very good Dr. MK doc. Yes, they are going to join and form the conjoint tendon. These two aponeuroses will join together to form what's a conjoint tendon. And where is conjoint tendon present? That is also present behind the inguinal canal. So what is going to form the posterior wall of the inguinal canal? The transversalis fascia along with the conjoint tendon. I will repeat once more for you people. Listen here very carefully. It is worth repeating. This will be the inguinal canal. So what do you have in front of the inguinal canal? What is forming the anterior wall? The anterior wall of the inguinal canal will be formed by external oblique and internal oblique. And what is forming the posterior wall of the inguinal canal? The posterior wall of the inguinal canal will be formed by the transversalis fascia and the conjoint tendon. Transversalis fascia and the conjoint tendon, guys. Superior, inferior is damn easy. You can see in my diagram there what is present superiorly. We are having internal oblique as well as transversus abdominis arching above that one. I repeat again, superiorly you will be able to see the internal oblique and transversus abdominis arching above that one. And what do you have inferiorly? Below this inguinal canal, what do you have, guys? Inguinal ligament. Below the inguinal canal, what do you have there? The inguinal ligament, guys. Fine. These are the boundaries. I hope you got the picture here. Now, once you are comfortable with the boundaries here of the inguinal canal, now my main intention here is the clinical application of this one. That is nothing but the inguinal hernia. Inguinal hernia. And let me give you one simple diagram here to remember that. Don't try to simply write down like the notes like paragraph and mug up that one, guys. I hate the mugging business. No mugging business in my class. So imagine this is like the anterior abdominal wall, and somewhere here is the deep inguinal ring, and then the triangle shaped superficial inguinal ring, the inguinal canal here. Now sometimes what is going to happen, the hernia is going to occur via the deep inguinal ring and then come out via the superficial inguinal ring, and this is referred to as the indirect inguinal hernia. So indirect inguinal hernia is going to occur via the deep inguinal ring. Indirect inguinal hernia will occur via the deep inguinal ring. Whereas what is going to happen here, that in the anterior abdominal wall there will be a triangle here, and this triangle is referred to as Hasselbalch's triangle. This triangle will be the Hasselbalch's triangle, and the herniation will occur from the Hasselbalch's triangle here. And if the hernia occurs via the Hasselbalch's triangle, that is referred to as the direct inguinal hernia. Easy. So if you just write it like paragraph, direct, indirect and all, so you'll be getting confused. Draw one simple diagram and you will never ever forget in your lifetime. So indirect inguinal hernia is going to occur via the deep inguinal ring, and direct inguinal hernia will occur via Hasselbalch's triangle. And now in anatomy, whenever you come across any triangle, rectangle, you got to learn the boundaries. So that's my work here. Let me teach you the boundaries of Hasselbalch's triangle. Look at this diagram here. First of all, try to understand the orientation here. In this diagram, this is a rectus abdominis muscle, your favorite muscle, which is going to form that the six packs, the abs. And there'll be like one more rectus abdominis muscle on the other side. And between the two rectus abdominis muscle, there will be linea alba. And this one here will be the pubic symphysis. So you're able to understand that it is one half of the diagram. Okay. Now rectus abdominis muscle will be forming the medial boundary. It's toward the medial side. This ligament that you're able to appreciate here is the inguinal ligament here. And then these blood vessels over here will be the inferior epigastric blood vessels. I repeat again, rectus abdominis muscle towards the medial side, inferior epigastric vessels towards the lateral side, and below the base will be formed by inguinal ligament. And this triangle is referred to as your Hasselbalch's triangle. And from here occurs the direct inguinal hernia. So direct inguinal hernia will occur via the Hasselbalch's triangle, and those are the boundaries of Hasselbalch's triangle, guys. So rectus abdominis muscle on the medial side, inferior epigastric on the lateral side, and inguinal ligament on the, forming the base there, guys. And in our regular classes, we'll be actually drawing this diagram and all, but now let us not waste our time in drawing these diagrams and also. So in the regular classes in detail, we can learn by drawing the diagram ourselves. Next one, guys. Another important topic here, that is about your diaphragm. I want you all to learn about the diaphragm here. See, when you look at this picture in the diaphragm, I know every student knows about those three major openings and all. So you are able to appreciate, first of all, this one here is the central tendon. This is the central tendon of the diaphragm. And then this one here will be the vena cava opening. How to identify the vena cava opening, sir? If this type of cadaveric image is given, how to identify? The vena cava opening will be present in the central tendon. the vena cava opening will be present in the central tendon. That is the best way to identify the vena cava opening. Then you are able to see one more opening here, which is in the muscular part, and that opening is referred to as your esophageal opening. That is esophageal opening in the muscular part. And then one more opening that you are able to see here, that is between the right and left crust of the diaphragm. This opening is nothing but the aortic opening, guys. Aortic opening. So there is a vena cava opening, the esophageal opening, and the aortic opening. There are three openings here, and my dear friends, that is present at the level of T8 and then T10 and T12. And people actually remember the numbers very well, 8, 10, 12 even numbers. But in the exam, during the exam, out of that anxiety, they will forget okay, which opening do you have the 8th one, which opening do you have the 10th one, and which opening do you have at the 12th one. In the class, yes sir, 8, 10, 12, easy to remember. But in the exam, remember, with the help of the mnemonic, voice of America. Vena cava opening, esophageal opening, and then aortic opening, sir. Voice of America. Okay. Thank you, MK Doc. Thank you. Thank you, Dr. Bowie. Voice of America, 8, 10, 12. Now, whatever these openings are there, I hope you all remember the structures which are going to pass from here. Vena cava opening, there will be inferior vena cava passing from there. Write down that and forget about that one, guys. Why? Because vena cava opening, it will be definitely inferior vena cava, and no one is going to ask these kind of silly things. Focus on the other things, sir. That is your right phrenic nerve is going to pass from here. Along with the inferior vena cava, there will be a right phrenic nerve passing from here. Esophageal opening, what is going to pass, guys? That will be esophagus passing from here. Write that esophagus and forget about that one. Why? Because they will never ask you in the exam. Esophageal opening, esophagus. Along with that, remember, vagus nerve is going to pass. And I remember that with the rhyming words. Esophagus, vagus. Esophagus, vagus. And aortic opening, definitely aorta is going to pass from here. And along with the aorta, there will be even thoracic duct and the azygous vein. Thoracic duct and the azygous vein, sir. So there will be aorta along with the thoracic duct and azygous vein. So I hope you are able to recall, review that very quickly. Done. I'm damn sure, I'm 110% sure, like most of the medical students will be already knowing this one. But my intention is not about diaphragm and the major openings of the diaphragm. My intention is mainly about the development of the diaphragm, guys. My intention is mainly to teach you about the development of the diaphragm. Welcome here, sir. I'm expecting a question from here in the next NEET PG exam. Why? Because there is a clinical correlation. I will tell you the clinical correlation. Observe here carefully. Development of diaphragm. Diaphragm is totally developing from 4 structures. Number 1, septum transversum. Number 2, the cervical myotomes. Okay. And number 3, you'll be having the dorsal mesoesophagus. And number 4, my dear friends, remember, the pleuroperitoneal membrane. And we are going to learn this with the help of an image, with the help of a diagram. Why? Because already in your exam, once they have given a image-based question, that too in the embryology, development of diaphragm. So we are going to draw the diagram in such a way that as if we are seeing the diaphragm from above. So there is a dome-shaped diaphragm, we are looking from above. So when you look at this dome-shaped diaphragm from above, yes, first of all, you'll be able to appreciate the septum transversum here. Septum transversum, and remember, septum transversum, it is the one which is going to form the central tendon. Septum transversum is the one which is going to form the central tendon, guys. Then apart from that, you'll be able to appreciate the cervical myotomes. The body wall, the cervical myotome, that is going to contribute the muscular part, the muscle part of the diaphragm. But you know, what is the point where the students will be getting confused? The word cervical. Cervical myotomes, most of the students are getting confused with the word cervical there. Why? Because diaphragm here, how come cervical, the neck region contributing? It's very simple, guys. What is the nerve which will be supplied to diaphragm? Yes, the muscles of the diaphragm, they'll be supplied by which nerve? They'll be supplied by phrenic nerve. And what is the root value of the phrenic nerve? The root value of the phrenic nerve will be C3, C4 and C5. C3, C4 and C5. Yes, definitely the diaphragm is actually getting the contribution from where? From the cervical region. The cervical myotomes, keep a concentration on this one here. Don't get confused. Now, apart from that, you have got your esophagus here. And then you'll be having that peritoneum layer coming here, enclosing and then again going back. So what is this double layer of the peritoneum known as a mesentery? And this one is present toward the dorsal side. So therefore dorsal mesoesophagus. Dorsal mesoesophagus. Dorsal mesoesophagus there, guys. And then whatever area is left out here and here, that is the one which is going to form your pleuroperitoneal membrane on one side here, and there will be pleuroperitoneal membrane on the other side. So pleuroperitoneal membrane will be paired. Now this is the exact diagram which was actually given in the exam. Septum transversum, yes, septum transversum, the central cervical myotomes, and then the pleuroperitoneal membrane and the dorsal mesoesophagus there. Okay, Jagdish Jakar, I cannot do anything for this one here agar maza nahi aa raha hai, because this is like the online thing, online platform, and I hope you have to agree with me. Okay, here it's not like the offline class, everything is like on record. So I have to be like this here. It's not like the offline class. Normally, I think you have seen me in the offline class. And these are all the high yield concepts which are required for the NEET PG students, and their exam is very much nearby. Just exactly, I think 10 days left right now. So, isliye fadafat I'm just going through like all the important concepts which are required for them, so that they're able to like quickly review the things that is getting fresh in their minds, so that at least it will be there in their temporary memories. If the question comes in the exam, then you should be able to, learn that. Septum transversum, and then cervical myotomes, the pleuroperitoneal membrane, and then the dorsal mesoesophagus. Now remember, sometimes what will happen, this pleuroperitoneal membrane will be absent. The pleuroperitoneal membrane will be absent. And if that membrane is absent, then what is going to happen, guys? Congenital diaphragmatic hernia. Congenital diaphragmatic hernia, I'm expecting a question based on this one in your exam. So congenital diaphragmatic hernia will occur due to the absence of pleuroperitoneal membrane. If that membrane is absent, it will lead to congenital diaphragmatic hernia. Okay. And one more thing, sometimes what will happen is that, okay, this membrane is present there, but it is very much thin. And if that membrane is like very much thin there, what is going to happen? It will lead to evertration of diaphragm. So all this question has been already asked in the exam. Like both of this question has been already asked in the exam, guys. So congenital diaphragmatic hernia and the evertration. I repeat again, absence of pleuroperitoneal membrane, congenital diaphragmatic hernia, and then if there is very much thin pleuroperitoneal membrane, it will lead to evertration of the diaphragm, Okay. Sir, is this the transverse section? Not exactly the transverse section of the diaphragm. Learn medicine easy. We are actually seeing the diaphragm from above. हम ऊपर से देख रहे हैं. So this is your dome shaped diaphragm and we are looking from above. So there will be central tendon, the muscular part, and the pleuroperitoneal membrane, and then the dorsal mesoesophagus. Lovely. Now once you are done with this, welcome to the next concept here. I think now Jakar will be enjoying. This is Dr. Jakar's favorite region. Welcome to the gluteal region here, sir. Now, gluteal region, first of all, there will be a big muscle overlapping there. That is your gluteus maximus muscle. But that gluteus maximus muscle we have removed from there. हमने ना वहाँ से gluteus maximus muscle निकाल दिया है. We have removed from there. Then you are able to see here, appreciate here, the gluteus medius muscle and the gluteus minimus muscle. Okay, gluteus medius muscle and the minimus muscle. And first try to identify all the muscles here, guys, very quickly. Gluteus medius and minimus. Then here in this diagram, you are able to appreciate that there is an opening here, and this opening will be the greater sciatic foramen. Greater sciatic foramen, and this muscle which we are able to see from here will be the piriformis. After that, there is a small muscle above here. This one will be gemellus superior, and then below that there will be obturator internus muscle here, and then below that there will be again gemellus inferior, and then there will be rectangle shaped muscle here, and whenever there is rectangle, quadratus, and that is nothing but the quadratus femoris muscle. Quadratus femoris muscle, guys. Okay. So there are like 4 muscles that you have to remember in order. Number 1, gemellus superior, and number 2, there will be obturator internus. Number 3, there will be gemellus inferior, and then there will be quadratus femoris. I repeat again, gemellus superior, and then the obturator internus, and then gemellus inferior, and then there will be quadratus femoris, the 4 muscles. And the one which is coming out from the greatosciatic foramen will be the piriformis muscle. Now, why I am telling you about these muscles here is why, because clinical importance here, medius and minimus, they are the one which are supplied by superior gluteal nerve, and if those muscles are gone, then what is going to happen here, guys? Yes, it will lead to lurching gait in which the Trendelenburg sign will be positive. So let us integrate our anatomy with orthopedics here, guys. Look here. Now don't try to look at all the diagrams at one time here. First of all, look at the first diagram. In the first diagram, you can clearly see the right foot is on the ground there and the left foot is off the ground. I mean to say in the air. While walking, the right foot is on the ground there, the left foot is off the ground. So what will happen is the left side of the pelvis will tend to fall down. Listen to me very carefully now, sir. It's a very, very important thing. The right foot on the ground, the left foot off the ground. So therefore, the left side of the pelvis is not supported. That is why the left side, what is going to happen? It is try to actually, what will happen, that the left side of the pelvis will tend to fall down. But that will be prevented. Are we falling down while walking? No, it will be prevented. How? It is prevented by your gluteus, medius and minimus muscle of opposite side, the contralateral side. The gluteus, medius and minimus muscle of the opposite side, the contralateral side. And these two are supplied by the nerve that is your superior gluteal nerve. Welcome here, sir. Now, sometimes what will happen is that if this superior gluteal nerve is gone, if it is injured, then the medius and minimus will be gone. They'll be paralyzed. Then how the person will walk? Now look at the second diagram now. Right foot on the ground, left foot off the ground, the left side of the pelvis will tend to fall down. But now what is going to happen is that the medius and minimus are not working. They are paralyzed. I'm just writing minus here. They're gone. They're paralyzed. Now they are unable to abduct there, guys. Ab kya kiya jaye? Because the medius and minimus is gone, it is unable to abduct there. So therefore, what I am trying to do right now, because these muscles are gone now, I will take the help of upper half of the body. You can see here the upper half of the body I am moving on the other side. The moment I move this upper half of the body, my pelvis will actually abduct here. The hip, the pelvis will abduct because the medius and minimus is not acting there. So therefore, the pelvis will abduct there. So right now it is like online live session here. I cannot show it practically, but normally in my offline classes, I will practically do it in front of all the students and show. Why? Because when you see it practically now, you will understand more better. It's a beautiful concept actually. You cannot understand this by just reading in paragraph. If you do it, then you can understand. So basically what we are doing here, we are lurching the entire upper half of the body. Upper half of the body, we are lurching here on the opposite side so that the hip will come up. And then the person is walking by lurching the body on one side here. Therefore, this type of gait is referred to as the lurching gait. What is this one? This is lurching gait. And in lurching gait, what is the muscle involved? The muscle involved will be medius and minimus. And what is the nerve involved? The superior gluteal nerve will be involved in this one, lurching gait. And which sign is positive here, guys? That is your Trendelenburg sign. Is it okay? Fine here. So that is what I am trying to actually tell you. This is also another very important, very potential clinical question here, guys. Understanding here? So that is the role of your medius and minimus. And apart from that, how can we leave this concept? Come on, welcome here. We cannot leave this concept at all. No. This is nowadays the hot favorite concept about the muscle attachment of all the muscles on the upper end of the femur. Upper end of the femur. I want you to review this very fast along with me in our quick revision program session here, guys. Come on, let's review. Why? Because last year 2020 there was a question given about the attachment of muscles to the femur, upper end of the femur, in almost every exam, whether it is NEET PG exam or INSET exam or even the FMG exam, this question was given there. So we cannot tend to forget that. That's why I have included that here in this session. इसलिए मैंने यहाँ पर include किया है. Mohanlal Chaudhary, namaskar sir. Sonali Mishra is asking, sir, is this video going to be available further? Let me know, Sonali Mishra, what do you want? You want me to keep this video? If you want me to keep this video, I'll surely keep this. Yes. Now, first of all, yes, look at this diagram here, and you have to identify in the exam which is the anterior view and which is the posterior view of the femur, anterior aspect and the posterior aspect. See, actually in the femur, what is going to happen? There will be a greater trochanter here, and this will be the lesser trochanter here, and between them you'll be able to appreciate one line, and that line is known as the intertrochanteric line. This line is intertrochanteric line. And if you are able to see intertrochanteric line, that is nothing but the anterior surface of the femur, anterior view of the femur. And then here you will be able to appreciate again the same thing here. There will be a greater trochanter here, that is greater trochanter here, and this one here will be the lesser trochanter here, lesser trochanter, and in between them if you are able to appreciate a crest here, guys. Intertrochanteric crest, not line. If there is a crest there, yes, that is nothing but the posterior view of the femur. तो पहले आपको ना ये पहचानना चाहिए. First you should be able to identify the anterior view of the femur and the posterior view of the femur. On the anterior side, you'll be able to appreciate the intertrochanteric line, and the posterior surface you'll be able to appreciate the intertrochanteric crest. Very good, Dr. Kamal. Now, now my dear doctors, look here. The question that was recently asked in your exams. Okay, welcome. Here I am able to find one tuberosity here, and this tuberosity will be the gluteal tuberosity. What is this tuberosity here, guys? That is your gluteal tuberosity. And the muscle that is getting inserted, look at that. I am using the same standard color that will be used in our textbooks, blue color for insertion. So don't get confused. The muscle that is getting inserted here on the gluteal tuberosity will be the gluteus maximus muscle. So gluteus maximus muscle will be inserting onto the gluteal tuberosity. Gluteal tuberosity. And not only on gluteal tuberosity, some of the fibers are getting inserted onto the iliotibial tract also. So gluteus maximus will be inserting there on iliotibial tract, as well as some of the fibers will be inserting on gluteal tuberosity. Next one. Now what is the muscle that is getting inserted onto the greater trochanter? Greater trochanter on the posterior surface, it will be the gluteus medius muscle. Gluteus medius muscle will be inserted onto the greater trochanter, but on which surface, guys? On the posterior surface of that one. Then what about the minimus? Gluteus minimus is also getting inserted onto the greater trochanter only, but it is more on the anterior surface of that. So to be like more specific, this will be the gluteus minimus muscle inserting onto the greater trochanter, but on which surface? Anterior surface. Whereas the gluteus medius muscle is also inserting onto the greater trochanter, but on which surface, guys? On the posterior surface. So this question is being asked a lot of times in the exams. So I want you to be like really perfect with medius, minimus and maximus muscle. And then what about the lesser trochanter? On the lesser trochanter, you'll be having your iliacus muscle inserting along with psoas major. Iliacus muscle inserting here along with the psoas major muscle. Okay, so that has been also tested in the exam in 2020. Okay, so attachments at the upper end of the femur are very much important here, guys. So that is why I have actually included this also in the quick revision program here, so that it will be refreshed in your mind if you skip that topic during revision, guys. Is it okay? So that is about all the concepts, guys, which I wanted to actually discuss here in the quick revision program on doctorals here, and I hope you have enjoyed this one here. So we have included the concepts which are mostly like clinically correlated with many topics in upper limb, the lower limb, the thorax, abdomen, the head and neck, neuroanatomy, and I hope you remember we have discussed about the tracts in the easiest manner. You can apply that to the brainstem syndromes and all. So these are all these selective topics that I have selected here to discuss, and there is a maximum probability of these type of questions coming in the exam. Okay. So for more videos, you can subscribe to our Doctorals app, available on every social media platform there. You can subscribe and you will be getting the notification of that, guys. So thank you all for listening to me very patiently here. So all the best to the exam, to the people who are going to write on the exam on 11th September 2021 NEET PG, and hope you come out with flying colors. Okay, so that's all for today, guys. Anything else, let me know. Drop a message in the comments there, and I'll get back to you. And we also have our a group there, Dr. Tutorials, on the Telegram group also. You can join there for all the latest updates, and you can watch the QRP session, the quick revision program session of all the national level best faculties at Dr. Tutorial. We have made a list of that one. There is a playlist on our YouTube channel. You can subscribe that and you can watch all the 19 subjects before your exam, guys. So thank you all. Thank you all for your time. And I think I have made the best of your time, whatever you have spent along with me. And all the best for your exam, guys. God bless you all. May you come out with the flying colors. You prepare well. You work hard. I'm praying for you. Thank you. Take care. Bye-bye.